I want to tell you about a patient of mine. His name is Robert. Robert is 74 years old, and he came to see me not because anything was dramatically wrong, but because his daughter had made him an appointment, the way daughters sometimes do, when they notice something that their father has been dismissing for too long. She had noticed that over the past 18 months, her father had stopped going up the stairs the way he used to. He had started taking them one at a time with his hand on the railing, pausing at the top for a moment before continuing. And she had noticed that when they walked from the car park to the restaurant, he would slow down just slightly in a way he had not slowed down the year before. And when she asked him about it, he said, "I am 74. That is just what happens." And she said, "Dad, I am making you an appointment because you said that last year and the year before that. And I want to know whether it is just what happens or whether it is something specific that someone should be looking at." Robert sat down in my office and he was not worried. He told me, "I feel fine, a little slower on the stairs, a bit more tired in the evenings, but I am 74. What do you expect?" His blood pressure was 138/84, which was higher than I wanted for a man his age, on a calcium channel blocker. His resting heart rate was 78. His weight was the same as the previous year. And when I listened to his heart with my stethoscope, I heard something that I wanted to investigate. A very soft sound between the normal heart sounds that his previous doctors may have heard or may not have, but that in the context of what his daughter had described, and in the context of a man who was 74 with blood pressure that had not been perfectly controlled for the past 8 years, I wanted to understand. More clearly, I said, "Robert, I want to order an echocardiogram for you, an ultrasound of your heart." And he said, "Is something wrong?" And I said, "I do not know yet, and I would rather find out than guess." 2 weeks later, the results came back, and I called Robert and asked him to come in and to bring his daughter if she was available. And they sat down together in my office, and I told them what the scan had found, and what I am going to tell you now is what I told Robert that afternoon, because Robert's story is not unique, and the finding on his echocardiogram is something that affects a very large number of adults over 65 with a history of elevated blood pressure who have been getting steadily more tired on stairs in ways they have been explaining as simply getting older, and which in many cases is something more specific than that, and something more addressable than that. I am Dr. Daniel Chen, and today I want to explain what Robert's echocardiogram showed, what it means, why it develops, and what every adult over 65 with elevated blood pressure and gradually increasing tiredness on exertion needs to understand about what may be happening inside their heart right now. So let me start with what an echocardiogram actually shows, because Robert had never had one, and most of my patients who have not had one do not fully understand what it is or what information it provides that other tests simply cannot give. An echocardiogram is an ultrasound examination of the heart. It uses sound waves to create real-time images of the heart's structure and function, including the size of each chamber, the thickness of the walls, the movement of the heart muscle with each contraction, the function of each of the 4 valves, and critically, for Robert's story, both the squeezing function of the heart, called systolic function, and the relaxing function, called diastolic function. That happens between beats, when the heart fills with blood. Now, most people, when they think about heart function, think about the squeezing, the contraction, the pumping. And the number that most people have heard of when discussing heart function is ejection fraction, the percentage of blood that the heart pumps out with each beat. Normal ejection fraction is above 55%, and Robert's ejection fraction was 57%. Technically normal. And if I had stopped reading the report at that number, I might have said, Robert, your heart is fine. Come back next year. But I did not stop at that number because the report contained several other findings that together told a much more important and much more specific story than the ejection fraction alone. The first finding was the left ventricular wall thickness. Robert's interventricular septum, the wall between the two sides of his heart, was 13.5 millimeters. Normal is below 12 millimeters. His posterior left ventricular wall was 12.8 millimeters, also above normal. His left ventricular mass index, a measure of the total mass of the heart's main pumping chamber, was 128 grams per meter squared. Normal for a man is below 115. Robert had left ventricular hypertrophy. His heart muscle was thickened, heavier than it should be. The consequence of years of pumping against higher resistance than normal, because his blood pressure had not been perfectly controlled for the better part of a decade. I have explained left ventricular hypertrophy in detail in a previous video about a patient called Richard who received the same diagnosis at 72. But I want to continue with what Robert's report showed beyond the wall thickness, because there was more. The second finding was the diastolic function parameters, and this is where Robert's story becomes specifically relevant to the tiredness that his daughter had noticed, and that Robert had been explaining as simply his age. Diastole, as I described in my video on left ventricular hypertrophy, is the phase of the cardiac cycle when the heart relaxes between beats and fills with blood. In a heart with thickened walls, the stiffened muscle cannot relax as freely or as completely as it should, and the filling of the heart with blood is impaired. This impaired filling is diastolic dysfunction, and it is measured on an echocardiogram through several specific parameters. Robert's report showed an E/A ratio of 0.7, which indicates impaired relaxation. The E wave, measured by Doppler ultrasound, represents early passive filling of the left ventricle. The A wave represents late filling, driven by the contraction of the atrium above. When the E/A ratio falls below 0.8, it means the heart is relying more heavily on the atrial kick, the late active filling, to compensate for the impaired early passive filling. That diastolic dysfunction produces his E velocity. A measure of the speed at which the heart muscle relaxes was 6.2 centimeters per second. Normal is above 7. And his E over E prime ratio, which estimates the filling pressure inside the left ventricle, was 14. A value above 14 indicates elevated filling pressures. And Robert's value of 14 was right at the threshold between normal and concerning filling pressures. Together, these three measurements indicated grade 1 diastolic dysfunction, impaired relaxation with filling pressures that were normal to borderline elevated at rest, but that would become more significantly elevated during exercise or exertion. And here is why that is. The precise explanation for what Robert's daughter had been watching on the stairs and in the car park for the past 18 months. When the heart with diastolic dysfunction needs to work harder during exercise or when climbing stairs, the demand for blood flow to the working muscles increases. The heart needs to beat faster and fill more completely with each beat to meet that increased demand. But a heart with diastolic dysfunction, a stiff heart that cannot relax and fill freely, cannot increase its filling as efficiently
as a normally compliant heart can. To compensate, the filling pressures inside the heart rise. And when the filling pressures in the left ventricle rise significantly, that pressure backs up into the left atrium and then into the pulmonary veins, the veins that carry blood from the lungs to the heart. And when pressure in the pulmonary veins rises, fluid begins to leak from those vessels into the lung tissue, causing the sensation that Robert knew very well, but had never connected to his heart. The slight breathlessness
On the stairs, the need to pause at the top to let it settle before continuing, the tiredness that had been gradually accumulating over 18 months as his diastolic function had gradually declined under years of elevated blood pressure and an aging heart muscle that was working harder than it was designed to. This pattern of preserved ejection fraction, meaning the squeezing function, looks normal, combined with impaired diastolic function, meaning the relaxing and filling is impaired, is called heart failure. With preserved ejection fraction, or HFpEF, and it is one of the most common and most underdiagnosed forms of heart disease in adults over 65, particularly in women, though Robert was a man, and it is in women where it is most commonly missed, because symptoms in women, as I have discussed, often present differently than in men. But in adults of any gender over 65 with a history of hypertension, the combination of preserved ejection fraction and gradually increasing exertional breathlessness and fatigue should prompt an echocardiogram and a careful examination of the diastolic function parameters that the ejection fraction does not reflect. Robert looked at me when I explained this, and he said, "So my heart is not failing?" And I said, "Your heart is working as hard as it can for a heart that has been under more strain than it should have been for a number of years. The squeezing is fine, but the relaxing is not quite right. And when you push it on the stairs or across the car park, it tells you, and the way it tells everyone, when the demand is more than the filling can meet." And he said, "Is that what is going to happen to my heart from now on?" And I said, "Robert, that depends very significantly on what we do now and on what we have been doing and what we change going forward." Let me tell you What I told Robert about management, because this is the part that matters most. Heart failure with preserved ejection fraction, particularly in its earlier stages, as Robert presented, with grade 1 diastolic dysfunction and borderline filling pressures, is a condition that responds meaningfully to the right management. The most important element is what I have discussed in detail in my video on left ventricular hypertrophy, aggressive blood pressure control to a target that for Robert, in the context of diastolic dysfunction, we set at below 120 systolic, consistently, not occasionally, not on his better days, consistently. Because the diastolic dysfunction that was causing his symptoms was the downstream consequence of years of elevated blood pressure acting on his left ventricular muscle, and the only way to slow its progression or achieve any degree of regression was to reduce the pressure that the muscle was responding to. In the first place, Robert's calcium channel blocker was not achieving that target. His readings were consistently around 138, which was not the 120 or below that his cardiac findings now required. We discussed adding an ACE inhibitor to his existing medication, specifically because, as I've explained, ACE inhibitors have specific evidence for supporting left ventricular regression in hypertensive heart disease, beyond their blood pressure lowering effect. And we titrated carefully over several weeks to reach the target without causing the orthostatic hypotension that I discussed in my video on dizziness on standing. And that becomes an increasing concern
as blood pressure targets are pushed lower in older adults. The second element was sodium restriction, as I've discussed in many previous videos in the specific context of diastolic dysfunction and elevated filling pressures. Sodium restriction
To below 1,500 milligrams per day is particularly important
because excess sodium increases fluid retention and blood volume, which increases the filling pressures that a stiff heart is already struggling to manage. Sodium restriction directly reduces the fluid burden that a diastolically dysfunctional heart has to manage with every beat. The third element was a specific and carefully supervised exercise program. And I want to explain why this matters. Because the instinct when someone is breathless on stairs is often to recommend that they take it easier, avoid the stairs, protect themselves from the activities that produce the symptoms. But that instinct is wrong. For diastolic dysfunction, the research on exercise in patients with heart failure with preserved ejection fraction has consistently shown that supervised aerobic exercise improves exercise tolerance, improves diastolic function parameters,
and improves quality of life in affected patients more effectively than rest or activity avoidance. Because the cardiovascular adaptations that occur with regular aerobic exercise, including improved cardiac compliance, reduced resting heart rate, and better autonomic regulation of blood pressure, all support the specific functional deficits of diastolic dysfunction in ways that rest simply does not. For Robert, I recommended a graduated walking program, starting with 15 minutes of flat walking at a comfortable pace that elevated his heart rate but did not produce significant breathlessness, and increasing by 5 minutes per week over the following 2 months, until he was walking 30 to 40 minutes 5 days per week, not rushing the stairs, but not avoiding them either, taking them at his own pace with the railing, but continuing to use them rather than substituting the lift, because every flight of stairs was a gentle cardiovascular stimulus that his heart needed, not a danger to be avoided. The fourth element was weight management. And I want to mention this specifically because there is a very clear and well-documented relationship between excess body weight, particularly abdominal obesity, and diastolic dysfunction. The mechanism involves both the increased cardiac output required to supply a larger body mass and the inflammatory and neurohormonal activation associated with visceral fat. That directly drives cardiac remodeling. Robert was not dramatically overweight. His BMI was 27.5, mildly overweight. But research has shown that even modest weight reduction in the mildly to moderately overweight range produces meaningful improvements in diastolic function parameters. On echocardiogram, we discussed a realistic and sustainable approach to bringing his weight to the lower end of normal over the following 12 months. Not a dramatic intervention, but a consistent, modest caloric reduction combined with the increased activity from the walking program that we expected would produce a meaningful change over time. The fifth element was repeat echocardiography at 12 months to assess whether the diastolic function parameters were responding to the management changes, whether the left ventricular mass was beginning to regress with the improved blood pressure control, and whether the filling pressures that had been borderline elevated were moving in the right direction. Robert listened to all of this, and then he sat quietly for a moment, and then he said, "Dr. Chen, my daughter was right to make me come." And I said, "She was, and I am glad she did, because what we found is real, and it matters, and what we are going to do about it starts today." And he nodded, and then he said something
that I want you to hear because it captures something important about what it means to understand your own body rather than simply living in it. He said, I have been telling myself for 18 months that the stairs were telling me I was getting older. And I was right, that they were telling me something. I was just wrong. About what? 6 months later, Robert came back with his daughter. His blood pressure was 118/74 on the combination of amlodipine and the ACE inhibitor we had added. His resting heart rate was 64, down from 78. He had lost 4 kilograms, and he was walking 35 minutes every morning without stopping on flat ground. He told me he was still taking the stairs, carefully, but without the pause at the top. That had been his habit for 18 months. His repeat echocardiogram showed a left ventricular mass index of 118 grams per meter squared, down from 128, a meaningful reduction in 6 months of proper blood pressure control. His E/E prime ratio was 11, down from 14, moving clearly away from the borderline elevated filling pressures that had been contributing to his symptoms. His daughter sat beside him, and she looked at those numbers, and she looked at her father, and she said, I told him the stairs were trying to tell him something. And I said, you were right, and you did exactly what a good daughter does. You made him come. Before the stairs had more to say than either of them were ready to hear. Let me bring everything together now. Gradual increasing tiredness on exertion, breathlessness that comes a little sooner than it did a year ago, the need to slow down on stairs or on longer walks that feel easy on flat ground. In adults over 65, with a history of elevated blood pressure, is not simply aging. It can be the earliest and most recognizable symptom of diastolic dysfunction, the impaired relaxation and filling of a left ventricle, whose walls have thickened under years of elevated pressure, and whose stiffened muscle can no longer relax and fill freely enough to meet the body's demands during even moderate exertion. Without the filling pressures rising to levels that cause breathlessness, diastolic dysfunction, and its consequence. Heart failure with preserved ejection fraction are among the most common and most underdiagnosed cardiac conditions in adults over 65. Precisely because the ejection fraction, the number most people know and most doctors check first, is preserved and looks normal, while the diastolic function, which requires a more detailed echocardiographic assessment to evaluate, is significantly impaired. If you are over 65 with a history of elevated blood pressure and you have noticed over the past year or two that you get a little more breathless on stairs than you used to, or that you slow down a little on walks that previously felt easy, I want you to ask your doctor for an echocardiogram, and specifically ask for an assessment of your diastolic function parameters, including the E/A ratio, the E prime velocity, and the E/E prime ratio, not just the ejection fraction, because the ejection fraction will very likely be normal. And without the diastolic parameters, the story that your heart is trying to tell will remain unread. You can say, I have been noticing increasing tiredness on exertion over the past year. Given my history of high blood pressure, I would like to discuss whether an echocardiogram looking specifically at diastolic function would be appropriate. That is a completely reasonable and clinically informed request. And a cardiologist or an internist who takes cardiac aging seriously will take it seriously. Robert's stairs were telling him something for 18 months before anyone listened properly. Your stairs may be telling you something too. And now you know how to make sure someone hears it.
I am Dr. Daniel Chen. If this video explains something that has been happening on your stairs or on your walks, and that you have been explaining as simply getting older, please share it with someone over 65 who has also been a little slower recently and who has not yet been told what that slowing might be trying to say. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me whether you have noticed any change in your breathlessness or tiredness on exertion over the past year or two, and whether anyone has ever ordered an echocardiogram for you. I read every single comment, and I genuinely look forward to hearing from you. Take care of your heart. It is working hard for you every single moment of every single day.
It deserves to be listened to properly.